and we will turn it over to Dr. Soltis.
All right. Well, thank you, Denise, for the introduction, and thanks everybody for allowing me to come today and to share advanced care planning topic with you. This is obviously not the most enthralling topic that we would have today, but definitely one of the most important, I think, that we could focus in on for our geriatric population and for our community. So Dr. Drost and some of our teams here in the last 6 months have spent a lot of time focusing on advanced care planning as we celebrated, and I shared that word loosely as a celebration, but April was Advanced Care Planning Month, and so we put some extra focus on that at Summa this year, and hopefully we'll continue to spread that momentum through our community through this full calendar year. So really excited that I got the opportunity that Sue invited me to do this early in the year and said I could talk about whatever I wanted, and I thought this was a good opportunity to spread some more knowledge about advanced care planning with people who may have some increased interest around this. So with that, a lot of our focus, I think it's great. I was kind of taking notes on all of your backgrounds as you were sharing. I love the diversity because I think there's something in this talk for everybody. So advanced care planning is not just focused on what physicians do or nurse practitioners do. It's really focused on what a team does, but it's also focused on what patients and their families do around advanced care planning. And so it's the integration of all of those components that make conversations and documents successful. And without all of that, we can really fall flat on bringing to life what they're intended to do when they're needed. So hopefully each of you will take something from this that maybe you'll use in your work. For those of you that are retired, maybe you'll use in your life. And for those of you that are not retired and are still working, you know, all of us should be considering some of this for our families and for ourselves. So look forward to having some conversation at the end. Okay, did my screen move, Denise?
Yes, you're on the objectives now.
I see Sue saying yes. So, okay, so just a couple of objectives. I wanted to highlight the difference between advanced care planning documents and goals of care conversations, because really those two things can be used often interchangeably. And they can be the same thing when talked about as a concept, but really very important to distinguish. Also reviewing when goals of care should be addressed, how to address goals of care in advanced care planning. And again, hearing so many of you being nurses and social workers, this could be something you incorporate into your clinical practices. Reviewing the different Ohio ACP documents, so ACP Advanced Care Planning documents, and then learning the relevance of these documents in clinical care. And then at the end, hopefully just understanding why both are truly important in the care delivery for patients. So this is a weird picture to put up for advanced care planning, but I love this image, and I found it when I did this for a residency talk some years ago. I love it in the setting of advanced care planning because many people don't understand that the completion of a paper document without the appropriate goals of care conversation to support the intent of that document often opens the ability for the document to fall short. So where it says goals of care when you can't assume the desired outcome, if we don't have that conversation, we don't know what the desired outcome truly is. So the conversation or the goals of care helps us to create the image of the desired outcome so that we can appropriately match the document to the clinical context. That's the heart of the advanced care planning. So in this image, the basic advanced care planning document says, my goal is to get rid of lice. Okay, so my goal is to not have CPR. That's the document. But what's the rest of the story? How do you get there? What does that mean? What's the clinical context? So the specific steps in applying. So get rid of the nits, prevent the spread. That's how I'm getting rid of my active lice. So we have to know more of the details of a story in order to unfold it. So to pull apart goals of care planning versus advanced care planning, let's talk about goals of care planning first. Goals of care, simply put, to me, is just a conversation. It's a discussion. So it's talking about what is meaningful in an individual's life. And then really thinking about how that fits into their health, both current and potential future application. So it's that expectation setting. So we may have some idea of what's to come for them. We may not. Most people feel like this is a very difficult conversation. Most clinicians feel like this is a very difficult conversation. So oftentimes the most important step of this entire process is creating a setting where people feel comfortable really talking about the most difficult topics in life. And many people don't like to focus in on themselves when they're talking about this stuff, right? It's how they want to make sure all their loved ones are cared for. And so sometimes that's the heart of it too, is allowing them a space where they can think about themselves in a selfish way that many people don't like to do. Advanced care planning, the what is it? It is taking that goals of care, so that deep conversation, and reviewing the wishes and the meaning parameters of living and translating that into the document. So the document that is clearly expressing their wishes. And this is the part where they're discussing the who they want help from, so their healthcare power of attorney, any other documents they might want, like a living will, and potentially a DNR form. So these are the advanced care planning documents that they may walk out of the office with. So putting that picture back together, goals of care conversation, advanced care planning documents. Together they start to make a story. So advanced care planning may come with many explanations. And again, you hear that kind of verbiage interchangeably. And I like to think of it as just talking about what matters with professionals and loved ones. This doesn't just happen in the office or in the hospital. The loved ones are the important part too, or the people that are important to them to hear it, so that you can use that conversation at some point in the future to match the treatment documents to the wishes if you can't participate. So more simply put, again, planning for the future. So we all do planning for the future, right? We plan for our vacations, we plan for our retirements, we plan what we're going to do with our retirement money. Many of us think about our health insurance, how we're going to tap into our Social Security, but oftentimes we don't think about the critical pieces of advanced care planning. This is really one of those critical things in planning for the future. Sometimes we talk about it in the construct of specifics. I listed a couple on here because I think they're just simple examples, but really the meat of it again is that high-level conversation about meaning and then planning. So it's not just about, I use some acronyms here, but a CVA with dysphagia, so a stroke with dysphagia. And what does that mean in the context of a feeding tube? Or a car accident and you have brain damage. Do you want life support? Those are very specific conversations that happen in acute settings. That's not future planning. That's happening in a hospital when there's an acute event happening. That's a very different conversation than advanced care planning, right? What we're talking about today is that advanced care planning. So when to address goals of care and advanced care planning? Life-changing events is my number one that I put on here because I think oftentimes we just don't think about this. Marriage, divorce, death, and illness. Maybe we think about the illness, right? We get a cancer diagnosis, we have a stroke diagnosis, sure. But the first two are oftentimes the ones we run into most in the healthcare setting. And Dr. Drost, being on our ethics committee and oftentimes getting some of these calls, could attest to this is where it gets sticky. People forget when they get a divorce, they may not want their ex-husband to be their decision maker anymore. And then they come to the hospital and they didn't change their advanced care planning documents. So using life-changing events, kind of those milestone events, are really important triggers to address goals of care. Annual wellness visits is going to be one of those pushes that we're looking at. So when people come in for that checkup, that annual Medicare wellness visit checkup, that's when we take the pulse on how they're doing in life and wellness. It's also where we should be asking some of these questions. We've started thinking about pediatric to adult transitions a little bit differently, especially in the scope of work that we're doing here at Summa, as we're really proactively working with our pediatric hospital in the area and trying to transition patients with a place to land when they're aging out of the pediatric space. So these are people who are becoming their own adult and becoming their own decision maker and empowering them to think about that too, right? Do they want mom? Do they want dad? Do they want somebody else to help them make those decisions? Hospitalizations and acute events, of course, again, when they come into the hospital and they have big decisions to make, that's a great time to initiate the conversations if we haven't already. And then the last one is just, I say, at the suggestion of thinking about it. If you heard somebody else did it and you thought, yeah, I should probably be thinking about it, that's a great time to do it, right? It's one of those things that we tuck away and we say we'll do it later, and oftentimes then it's too late and we never get to it. How to address the goals of care. So I tried to break down goals of care simply and advanced care planning simply. This is reflective of something that we do out at the medical school at the end of the academic year with our graduating medical students every year. So this is based on the SPIKES protocol, and many of you may have seen this before. And again, this is not just physician-based. This is oftentimes something that our care managers or our care navigators who know our patients can sit down and really start addressing. This is a great tool for people who have developed relationships with patients that they follow over a course of time. I'm going to break each one of these components down further into the next slides. And then at the end of this, I'll share that at Summa, we've also created an electronic survey to send to our patients so that their primary physicians have a place to start when they arrive at their visits, particularly at their annual wellness that I'm going to share with you later. But it's really just to help people have tools, because most people in healthcare will tell you that this is not easy. It's often uncomfortable for them because it's tough stuff to sit and talk about. And they really don't know how to get started. So again, hopefully this will give you some simple tools to put in a toolbox that maybe you'll remember somewhere along the way to help you get started with some patients that you feel like maybe you could give it a go. So the first part here, we start with perception. So here are a few examples, and it is best if clinicians find a few that they're most comfortable with and really put those in your toolbox for the conversations. So I like to begin with something very simple, such as for a healthy patient addressing annual goals of care, I would say something like, where are you with your overall health right now? So, we're all taught, start with those open-ended conversation questions, not yes or no. We want to make them feel comfortable so that they can start having some conversation with you. And if I'm talking with someone who has a chronic and progressive illness, I may say something more along the lines of, what have you been told about your medical condition so far? And the most important part, again, of this is opening up a conversation. So questions that are open-ended and give them time to think. The most difficult part of this sometimes, I would say, and when we teach other colleagues to do this, is sitting in some pauses or sitting in some silences can be uncomfortable for us, but it gives people, they're not going to come off the cuff with these answers sometimes. They need to sit and process for a minute. And it's okay for us to hold our breath and not fill the silence with our own level of discomfort. Give them a minute to think of the answers. The next component of spikes is information. So this is the key area to assess what information they have, what information they want, and then how they want it. So this would be different based on whether or not you're doing a well visit goals of care or they've been given a bad prognosis or a new illness diagnosis conversation. So this is really to assess what information they have, what information they want, and then how they want it. So this is maybe you're talking about what lab tests you need to share with them right now, or it could be future. You know, when they have something come up, how do they want information? I think about this as comparable to a learning style. So do they like to learn in groups? Example, like, do they want their family present? Do they like to learn everything at once? So give them all the information about a disease all at once. Or do they like to get a little bit at a time, go home, do some reading, come back with questions? It's really a key to helping to develop a safe space where patients can come back and enter into that same space again, especially over time, knowing that they will be met with that same approach from you, so that you're learning their values and what's really important to them about information. This is the key to developing that relationship. Not every patient is the same. And this is based on what they want to know. So depending on where they are in their health or illness trajectory of life, knowing a few of these kind of statements are very helpful. And having these conversations with well-aging or healthy aging adults is also incredibly important. So in order to plan for the future, right? Or if we have difficult news in the future, starting some of these statements like that. And then, of course, if it's a difficult day, say things like, I want to share with you my understanding. And assess if that's okay. Say, do you need somebody else here for that to be a comfortable situation for you? The next section is about identifying what is important to our patients, including in health and in sickness. So we think about our current and our future states, and we think about our values and really how the values we have, all of us hold our own values, and they're the anchor to how we direct our care and how we connect with our world every day. So knowing these, and I'm going to highlight this, documenting these, are critical to helping guide our patients as their health changes. So we have a saying in medicine that if you didn't document it, it didn't happen. I would say that that applies to advanced care planning and goals of care as much as anything, because this is a conversation that needs to be transmissible from encounter to encounter. People need to be able to find it and help to inform how care goes forward. So documentation is super important. In this slide, you see a few examples of potential statements to help you get started. And again, they can be applied to healthy or ill patients, depending on the situation. And again, this does not take the physician level to have these conversations. It probably comes better most of the time from other team members. So what worries you about the future? What are your hopes? What happens if you get sick? Given this situation, what's most important to you? And then summarizing. So as I listen to you, it sounds like the most important things to you are. And make sure you have it right, because if you're going to document things that may impact their care in the future, you want to make sure that you're summarizing in a way that they would sign off on, that they agree with. You're being a spokesperson for them in that way. discussing what is acceptable, and I say in parentheses because I believe that they're often equally important. So helping them to remember they are at the center of their care team can really put them at ease during these difficult conversations. And it is often hard for patients to consider themselves before their loved ones or their caregivers. And again, I stated earlier, reminding them that it's okay to think about how they feel in these moments can often be very empowering. So when you think and encourage them about these things, we ask questions like, what makes life worth living for you? And then maybe the counterpart to that is there a circumstance when life would not be worth living? And sometimes you get really surprising answers from that. We had one recently that said, if I can't drive my stick shift, it's not worth living to me, right? And the situation was they had a stroke, that they would never use the right side of their body again. So how does that come into play with decision making rather than just having a document? That starts to impact that conversation very differently. So knowing what's important and what is acceptable and unacceptable, and also what are the things that they might change their minds about, things that they might find unacceptable today, but would you ever change your mind about that, maybe in a year? Sometimes people do change their minds, and would they ever consider that is really an important thing to poke at and to ask questions. Next part is about helping us to align their values and goals. So this is the portion of the conversation where patients and families often need the clinical team to support and help them to understand that their goals are actually achievable within the construct of their values. So an example would be if a goal is to drive again, as their expressed value is having functional independence, and yet they had the massive stroke that will forever leave them bedbound. Is that an achievable goal? As I stated before, this can start to lead us into some of those questions and conversations, and it can really help us to identify whether or not their goals being achievable as they had stated, are they able to have some malleability in that? And using some of these statements like, let's talk about the options and figure out which ones will help you meet your goals, or do they understand that their care choices will not align with their stated goals? So if we had this patient I referenced earlier who was choosing to have a feeding tube, right? They elected to have a feeding tube because they were under the belief that if they had a feeding tube, they would get strong enough to drive their stick shift again. That was the goal. Conversation was not held up until that point that the feeding tube was not going to achieve that goal. Feeding tube was not going to be reversible, and it was not going to get to that goal. So it starts to bring forward a conversation with family, next of kin, power of attorney, and patient, and helping them to share and have alignment, which eventually resulted in a patient choosing a comfort-focused approach, knowing that nothing they did was going to get them back to functional independence. So choosing a very different route than what they initially would have, because the conversation from the clinical team helped to support and build a story around whether or not their goals were achievable. The final part here, the final component with the patient and family is to summarize, again, to make sure you have it right. So based on what you've said, it seems like the most reasonable course of action is, and then propose recommended options. Make sure they are hearing you, that they agree, documenting that, and then, of course, at the end of that conversation, sharing with them that the team is here to support them, right? Even if they choose non-aggressive care, the team is here to support you and your family, that we're not going to abandon them despite the decisions. So the final piece of the clinician's work is, again, to document that. who was there, when it happened, what specifically was discussed, what was acceptable and not acceptable, and then any advanced care planning documents that were actually completed at that encounter. So that's the summary of goals of care or spikes. How to address advanced care planning, I break down into 5 steps. Now that you got the hard part out of the way through goals of care, advanced care planning really should seem like a breeze. And this could and maybe should be done at the same time intervals as the goals of care conversation. So the 5 components of this walk through. So step 1 is to introduce the topic. So patients usually won't start this conversation. And the medical community certainly needs to get more comfortable because patients believe that it is the physician's responsibility. There are gaps in this, however, because again, the medical team oftentimes doesn't feel comfortable doing it, and oftentimes they're not provided the time built into the workday to do such work because it does take time. I just went through a lengthy conversation guide on how to work through this, and it takes time. So there's definitely the opportunity for introduction on both sides. So as I shared with you earlier, I think everybody on the team has the opportunity to start the introduction of this topic. But I also think our community can certainly help to engage in this conversation and bring it to their providers. Step 2 is engaging in the structured discussion. So this should be easy if you have already had the goals of care conversation. The key component here that's just a little bit different than the goals of care. Goals of care, I offered the information piece of, do you need somebody else here? Do you want other people here supporting this conversation? Step 2, for goals of care, advanced care planning documents, we really encourage having the proxy present or at least aware of what's made in terms of decisions on documentation. Simply to help eliminate the surprises when the documents need to be applied to care. It is certainly easier when people know that they've been named as a healthcare power of attorney, or that a mom or dad or child or whomever has a DNR or a living will and it doesn't come as a surprise to them. And it is definitely helpful if they know what their wishes are when they're asked to speak on their behalf. So in that conversation, we talk about decisions that may come at the end of life. And when eliciting preferences, some of the topics that can be discussed, I have here on the slide. These are often the key clinical questions that patients and families face when electing to continue aggressive therapies or to forego these treatments in electing comfort at the end of life. So this is the conversation or the documentation type stuff that we often are looking for, whether or not people want to have chest compressions in the event of a cardiac arrest, if they want a ventilator or a breathing machine, if they can't breathe on their own. We talk about artificial nutrition or hydration. Meaning, do they want IVs, feeding tubes? Not just do you want them, but we also ask the questions of, do you want them temporarily or a trial, a time-limited trial? And if so, what does that look like for you? Sometimes people will say, I'll try it for 3 months while I try to get better. And after that, if I'm not better, I don't want it. Dialysis. Same thing. Sometimes there's a time-limited trial around that. If my kidneys can bounce back after an injury in 6 months, but I don't want to be on that for 5 years. Antibiotics, also an important question, especially for people that we see have reoccurring infections. We often talk about comfort care and what that looks like. And then, of course, the big questions that we're all asked when we get our driver's license is about donations. And as I mentioned, physicians are unfortunately not often allotted the amount of time to complete these tasks in a normal visit, and many feel patients will bring up this topic when they desire. So in an effort to increase goals of care and advanced care planning, we do encourage our community to become more activated around their own healthcare discussions. And so these are some of the questions that we just start suggesting for thought and engaging people to think about bringing into their care team. So understanding your disease process. So asking your doctor just what to expect. If you have a dementia diagnosis or a heart failure diagnosis, just simply, what should I expect out of this? Elderly population with heart failure, 8% of patients say they know what to expect. That means 92% of the population doesn't. Most likely because the doctors didn't openly share it, but also because they didn't ask. So we can encourage our patients to ask these questions. Asking us, people in our lives, our families, ourselves, considering your personal values, what's important? Is it more important to have more days of life or more life in those days? So that's that quantity versus quality question that we often think about in palliative care and geriatrics as well. And then the big hanging question, what makes life meaningful to you? So thinking through some of these things I mentioned earlier, we put a lot of effort here at Summa in the last year around advanced care planning and created a new platform, a questionnaire we're going to be working on sending to our patients prior to their annual wellness visits in the coming year, particularly our aging population, to try to start some of these conversations with our primary care docs. And so I just wanted to share this with you so you have an idea of the kind of sharing with our community. There are many options very similar to this on the market, 5 Wishes and other brand topics out there, of course, that are open for people to look up and purchase. But these are the questions that we settled on as a team to be potentially most helpful. And you can see some of them are similar to the questions that I've put up here before, but we also did get into some heavier questions like, what does a peaceful death look like to you? And would you be surprised if you died in the next year? So that's that surprise question. We think about whether or not somebody is hospice appropriate, but also some really simple questions like, if you have difficult conversations that need to be had, who do you want present for those conversations? Or what does quality of life look like? Our patients, of course, don't have to answer all of these questions. They can choose which ones feel best to them. And then, of course, there can certainly be more specific disease-specific questions for those who are at risk. I just want to say it's very hard to predict what one individual will face at the end of life without a known chronic or life-limiting illness. So, we really try not to hone in too specifically to those questions. That's why I'm really trying to drive home that values question and what's important to people so that we can apply it later on in their diseases. Of course, for our geriatric friends that see all of this large population of dementia, some of these things are important because we forecast what's coming. But even for our dementia patients, they may not survive to that feeding tube question. They may have a stroke ahead of time, or they may develop cancer ahead of time. So it's not always that we can predict exactly what's going to happen. So unfortunately, many times we just need to speak in generalities and anchor our decision making on the values. That's why it's so critical to understand them. So back to our 5 steps. Step 3 is documenting their preferences after discussion with the patient and proxy and providing copies. Step 4 is periodic review, again, at those clinical status changes, wellness visits. And then step 5 is applying. And this can be sometimes the most challenging, especially if the attention hasn't been to follow the other steps quite carefully. And again, what is the document? It's a legal document that only goes into effect if you're incapacitated and unable to speak for yourself, out of a disease process or severe injury, no matter how old you are. So a brief overview here of the types of advanced directives. Depending on where you live, there's a variety. I'm going to dive into these a little bit deeper here. We use the Ohio State Form DNR for code status. We do not have PULSE and MOLST in the state of Ohio. The living will is my least favorite of all documents. It's very vague, it's hard to interpret, and it's a very unlikely situation that it's helpful. So the language used is permanently unconscious state and terminal condition, and then I pulled from our Ohio living will document what that means. So if you think of anybody in your personal life that you've known, or any patient that you've known that has died, and how many of them have actually fallen into one of these categories, most of the time they just don't. So when people rely solely on a living will to help them to be expressive of their wishes, it really falls short of being able to communicate to the medical team. So permanently unconscious means permanently unaware of myself and my surroundings, meaning total loss of higher brain function. Okay? Unable to feel pain or suffering. You're essentially dead at that point. All but being brain dead. That is an unlikely situation for most people. Terminal condition means incurable and untreatable, and that my physician and one other physician will have examined me and believe that I cannot recover, and that death is likely to occur within a relatively short time frame. So again, it's very vague. What does relatively short time frame mean? So you will find very few physicians who are willing to say the living will is enacted here because of the language. So ultimately not helpful unless it's accompanied by a goals of care documentation otherwise. The medical power of attorney we find incredibly helpful in healthcare. So this is a person who's designated to make medical decisions by the patient if the patient is unable to make informed decisions. I just highlight a couple things. This is not necessarily an next of kin. I feel the power of attorney should be the person you trust most, not with maybe your finances, but it is the person you trust to speak on your behalf. So not the person that you think makes the best decisions, but the person who knows your values and can best apply your values to any situation. That's what we ask of them when we sit down and have conversations. What would this patient say if they could speak on their own? We're not asking for their opinion necessarily, right? We're asking for them to speak on behalf of the patient. The other key is they don't have to be consented. But back to the prior slide, we do advise that people share with their healthcare power of attorney that they've named them. Let's not catch them by surprise. They cannot name somebody else. So they don't have to take you up on your offer. But chances are, if we're reaching out to them, you're not able to pick somebody else, and they can't pick somebody on your behalf. So pick somebody, let them know, and then, of course, think about this. It's obviously a very important decision. If you don't have a healthcare power of attorney in the state of Ohio, it does default to the legal next of kin. We follow the surrogate priority for Ohio is spouse, and then adult child, parents, then adult siblings, and then nearest adult relative. If we can't find any of those in that order, then usually most health systems have policies in place to help find someone. An ethics committee or a legal team will make recommendations and usually have some form of reasonable effort to find next of kin prior to filing guardianship, which is a whole different lengthy process. The final document to review for the state of Ohio is the Ohio DNR form. Essentially, there are two choices on the Ohio DNR form. A DNR CCA means all treatments will continue until the event of a cardiac arrest or until the heart stops. And then when the heart stops, comfort care is initiated. There is no language on the Ohio DNR about ventilators or respiratory failure. And then a DNR CCO is the other option, which means comfort care. It does not mean do nothing. There are other options within that, pain medication, oxygen, hydration, depending on the patient. I recommend that we keep this visible at home. Just to show you the simplicity of this form, if you've never seen it, you see the two check boxes, DNR CC, that's comfort care, and then the CCA, CC arrest. Most impulse I share with you, just to say it's not legal in Ohio, but it can be helpful to guide you through documentation for those who have not a great comfort in completing advanced directives. I shared this as a picture just to show an example that has much more detail in what to do other than in the event of cardiac arrest. So it suggests other things such as the nutrition and hydration, including time-limited trials, and then also allows additional orders to be written in, which is not acceptable in the state of Ohio. For time's sake, I am going to skip ahead here. You must have, these are true, just a couple true and false. You must have a living will to stop treatment near the end of life. And the answer to that is false. Treatment can be stopped without a living will. A lot of this defaults back to the healthcare power of attorney. And I share this. I love that we have a hospice social worker on the call today. So just to show you, this is a hospice National Healthcare Statistics report for hospice patients that shared hospice patients across the country. Only 25% of them actually have living wills. And I'm okay with that, again, because I don't think that they're ultimately very helpful, right? A DNR is much more helpful than a living will.
Mm-hmm.
Most states do not require a particular form, but do require witnessing of a specific signing formality for your advance directive.
True.
That is true. True. So even if your state requires a specific form, doctors still have a legal obligation to respect your treatment wishes. So the best and most helpful advance directives I have had the opportunity to use have been truly handwritten express documents that people have had two friends witness when they've decided what they wanted done. And I'm going to share this tattoo with you because I love it. This is a very clearly written express wish. Do not put this person on artificial life support of any kind for any reason whatsoever. And do use the body parts, right? And then cremate all that remains, and of course has the witness signatures also tattooed on. Advance directives are legally binding, so doctors have to follow them.
Okay.
That is unfortunately not true. So more reason why to empower your healthcare power of attorney to know your wishes so that they can help fight if there's a situation where the doctors may not agree with your decision. Advance directives are only for older people.
False.
Also false. Some of the most well-known right to die cases were experienced by young people. Tragedies. And across the country, we don't have enough advanced care planning and goals of care happening. So this is just sharing a percentage of people who have completed advanced directives across the country, and we rarely top 40%. So I know we only have a couple minutes left, so I'm just going to share quickly, and hopefully this will help you to think through this case. One of my partners actually called me with this one just last week or the week before. This is a geriatrics patient that we share through our palliative program and our geriatrics team. So she's 75 years old and she's homebound. She has advanced Alzheimer's disease and she's minimally verbal. She's got infections that are happening over and over again because of her inability to swallow. Continent, in her bed most of the time, and has fully dependent in her care needs. And the social component of this is her daughter, we'll call her daughter number 1, is her full-time caregiver. She lives with her. And she expresses that her mom's quality of life is unacceptable. That if she believes if her mom could speak, she would say this is not acceptable, and she wouldn't want to go back to the hospital, and she thinks that she should be on hospice. The latest hospitalization, which was just a few weeks prior, the critical care doctors started initiating conversations about a feeding tube with her to prevent further aspiration pneumonia. So when we think about her advanced care planning, she has a full code. She does not have a DNR form. Her healthcare power of attorney is daughter number 2. She's estranged. She has not seen the patient in over a year. She returns no phone calls for the healthcare team for meetings or updates from the house team or the hospital team. She has no living will. There are no goals of care conversations documented. And under her values, her daughter said her core values, she was a teacher, an avid reader. She loved singing in her church choir. She was incredibly active in her women's group, her Bible study, and she loved her vegetable gardening. So, on that note, would advanced directives be helpful? Advanced directive documents. Any thoughts?
Would they be helpful? I feel they are.
DNR.
How about a living will?
I think definitely they could be helpful. It seems like there was probably opportunities to initiate these conversations, maybe with a nurse practitioner, a physician. Obviously, you know, someone has spent time with her. She's got 2 daughters. I think that I've spent a great deal of time working in hospice and home care, but more so hospice, that we get to the end of life and it's total chaos.
Mm-hmm.
Yeah.
And it's chaos for the family, and it makes for a very unpeaceful death for someone to not have these things in place. And having these discussions early on, and I do understand, you know, we're dealing more so with the older population, but having them with people who have chronic illnesses, you know, to make death peaceful and a peaceful thing. Knowing her wishes and knowing what was important to her is absolutely valuable. And a lot of these healthcare power of attorney issues, there's so many fights that happen between siblings. Unfortunately, there's so many family dynamics that need to be considered. So the sooner the better. I preach it.
Right.
What do you think would have been the key opportunity to initiate this conversation for this patient?
Possibly maybe with both daughters present, if that were an opportunity, or to set up a Zoom call with the daughter that hasn't seen mom, or if she's out of town, you know, include the family members so everybody's on the same page, you know, and meaning earlier on in her diagnosis or decline, okay, mom's fallen 3 times, or, you know, you've fallen here, your health has declined, you know, what's important to you, and have the family be part of that conversation earlier on, or as she continues to go back to the hospital or have a decline.
maybe at diagnosis when she was first diagnosed, or maybe since the healthcare power of attorney was the daughter who moved away when that changed.
Yeah. Yeah, and honestly, the fourth question I have on here, how can HPOA issues be avoided such as this? So the daughter didn't move away. She's local. She just refuses to participate now. She's disengaged. So, you know, one of the things we've talked about strategically, I think, is the importance of that secondary healthcare power of attorney naming. I think sometimes it's hard enough for people to come up with the first one. Or how do you rank your children in order? You know, who do you want to be first or who do you want to be second? But walking patients through why is it important to have a second too is definitely a topic that we've talked through since this case came up in the home setting.
How does that work, Dr. Soltis, when they have, if the healthcare power of attorney was in place and now she has advanced Alzheimer's where maybe she can't make her own decisions? How does that work with getting that changed?
Unfortunately, it's not so easy at this point. So we actually, this case, because she's not in the hospital, she's outside of the scope of the domain of our ethics in legal counsel for active intervention. So we had two choices. One is to wait for her next hospitalization, which is probably not too terribly far away for her next pneumonia. And then our ethics committee can get involved at that point. And then two is to go ahead and encourage the daughter to pursue a legal guardianship through the Summit County courts, which we know at this point it's not an emergency guardianship and it can take up to 3 months to get. So either way, we're probably looking at a few months for some completion of this process, which we all know as a family member is not what you want to have to focus on when you want to just take care of your mom, right? So none of these answers are easy. I think reflecting back to, and I appreciate the conversation about whether advanced directives are helpful. Again, living will, neither the terminal or permanently unconscious state is going to apply to this patient. So the big question that she's going to be facing is a PEG tube, right? Is she going to get a feeding tube? That's the next big kind of fork in the road for her illness. And how do we make that decision? I think the most important thing that we could have at that point is the goals of care conversation documentation. A DNR will be helpful if she arrests from an aspiration or gets septic. But again, it's only about a cardiac arrest. So up until that point, I think a goals of care conversation, when she had the faculties to be able to have that conversation, I think that's the part that we own for our patients, and that we can all strive to do a better job at documenting when we can and while we can, because we all know those windows close, those doors close, and we lose that ability. And what we see in this case is, unfortunately, the daughter is feeling that. We see it for her, but we're not feeling it day to day. And we had the opportunity to do something different. So learning from that and taking that to the next patient, I think is the key.
Okay, well, we are over time. And thank you, Dr. Soltis, for all of your insights and your wonderful presentation.